Well, good afternoon, everybody. My name is John Mitchell. I'm the director of ALNAP, and it's my pleasure to welcome you to this webinar to launch the new guidance document on humanitarian response to COVID-19. Now, we're going to address some key questions and issues, and to help us do this, we have 4 guests who are especially well positioned to provide advice and guidance to all of us. But before we start, I'd like to share a thought which seems to me to be particularly important at this moment in time. All of us are faced with an unprecedented global emergency. And in this context, the importance of learning cannot be underestimated. And here, I don't just mean learning from the past, but also learning whilst doing. Now, the point here is that over the years, humanitarian agencies have become more successful in capturing lessons and experiences through evaluations and other retrospective methodologies. But we've been less effective in using this knowledge to bring about positive changes in planning and in programming. And we've also struggled to learn in real time and to adapt our programs to make them more relevant. So with this in mind, this paper should be seen very much as a live document, and we're going to put capacities in place to help us catch experiences on the ground as they happen so that we can update the lessons and the guidance accordingly. And so in this way, I hope we can keep the material and content as current and as useful as possible. And just one more thing, for those of you who don't know, we do have a COVID portal on our website, which holds at the moment around 800 useful resources. And we're also updating this regularly. And there are also other listings of other COVID-related events, which can also enhance learning. So, without further ado, it's my pleasure to hand you over to our chair, Alice Obrecht, who is going to guide us through the next hour. Alice, over to you.
Great, thank you very much, John, and welcome to everyone joining us on the webinar today. As John mentions, we're taking a very practical and proactive approach to learning during the COVID-19 pandemic, and so we're going to be keeping this webinar also very short and practical. I'm going to do very little by way of introduction. I'd simply like to frame our discussion this afternoon with the question that ALNAP sought to answer in the Rapid Learning Review, which is the paper that forms the backbone for the webinar discussion today. And that is the question, how should humanitarian organizations prepare and respond to COVID-19 in humanitarian settings? And specifically, what do current evidence and experience tell us about the key actions that donors, agencies, and local organizations need to be taking, both when working alongside government health systems and in circumstances where humanitarians themselves are the primary health providers? To help us answer these broad questions and also discuss your more specific questions around COVID-19 response, we're pleased to have an incredibly experienced and high-quality set of panelists. These panelists also offer a cross-section of perspectives from across the humanitarian system, which is really helpful. So I'm going to start off by introducing Neha Singh. Neha is a co-author of the ALNAP Rapid Learning Review. Neha is also the co-director of the Health and Humanitarian Crisis Centre at the London School of Hygiene and Tropical Medicine. We also have on the panel Linda Duhl, who is the Global Health Cluster Coordinator based at the World Health Organization, and Iman Halil, who is the Health Coordinator for the International Medical Corps Lebanon office. And then finally, we are joined by Barbara Leck, who is the Senior Humanitarian Advisor at the Conflict, Humanitarian and Security Department for the UK Department for International Development, UK DFID. Now, we've received a large number of questions from you in advance of the webinar today, which we will be posing to our panelists after a short presentation of the paper's key findings. But please also feel free to submit new questions that you have. You can do that using the question section. There should be a pop-out box on your screen that's in front of the video screen. And on the right side of that screen, you should be able to see a gray box that says questions. It should be above the chat section. You can use the questions section of that box to ask your questions, and we will use that in the Q&A. In terms of the structure of how we're going to be running this webinar, we have, as you'll have seen, an hour. So we'll be starting with a very short presentation of the paper from Neha and then going straight into Q&A. And I would just add before handing over to Neha that John mentioned the resource portal that ALNAP is hosting, which hosts both the paper that we've published as well as a wealth of other resources on COVID-19. And you can find that at covid19.alnap.org or by following our Twitter account at ALNAP. So without any further ado, I'm going to hand over to Neha to give us a presentation of the key actions that her research team found in this rapid learning review for humanitarian organizations in preparing and responding for COVID-19.
Thank you, Alice. Thank you very much for having me on the webinar. I'm just going to very, very briefly take you through the key guidance in our report. So just to say that this is we did quite a lot of work with Ben Ramalingam from ODI, Carl Blanchet from CERAH, and Audrey Maheu. I think the rationale for this report was, okay, we know we have now well over 200 countries with confirmed COVID-19 cases, the majority of which are in settings affected by humanitarian crises. And by that, I mean both natural disasters as well as armed conflict. We know and we've seen sort of across the world that given the pandemic, a business as usual model for humanitarian actors just will not make for an effective response. We've seen quite a lot of guidance documents on specific aspects of COVID-19, as well as several advocacy documents and calls for action to include crisis-affected populations in response. So what we aimed to do was to actually look across all the guidance for COVID-19, including all the latest literature from COVID-19, even in high-income countries, as well as, of course, low and middle-income countries, but also to look back at previous outbreaks. So we looked at Ebola, cholera, MERS, SARS, and we did a rapid review, but we also spoke to over 40 stakeholders from local, national, and international levels, all humanitarian decision makers. And so what we did was we distilled all that evidence into a comprehensive set of actions that humanitarian organizations should take to prepare, adapt, and scale up their efforts when responding to COVID-19 in humanitarian settings. And we've distilled this latest evidence and field insights into 14 key actions and 7 cross-cutting guiding principles. So the actions here are, I'm not going to go into all 14 of them in detail. They're available on the ALNAP website. But just to say that the pillars are divided into sort of 5 of them. The first one is on preparing the health system. And we know that many humanitarian organizations are well underway in doing this. So supporting national efforts to assess COVID-19 impacts as well as surge capacities, developing and communicating very clear scenarios, guidance, and protocols, and also supporting integrated and coordinated decision-making and oversight. The next one is on preparing institutions and facilities. And this is where we're saying, okay, just start preparing at the community level and then across the continuum up through health facilities. Prioritize people, money, essential services and goods, and try to ensure availability of PPE for health workers as well as for support staff. Moving on to strengthening detection. We're advocating for prioritizing syndromic facility-based surveillance and to adapt the testing approach to transmission scenarios as defined by WHO, and also the testing capacity, which we know is a huge issue in many low resource settings, and also in the UK where I'm sitting right now. So moving on to the 4th pillar, which I think is potentially the most important, especially given capacities in many of these settings, is investing in prevention. So when targeting, accounting for, and supporting the most vulnerable groups, employing the right containment approaches to reduce transmission, and also very importantly, socially and economically supporting these approaches to quarantine and isolation. Finally, we have a couple of actions on enhancing case management, and this is about adapting health facilities and protocols, and then also where appropriate and relevant, delivering critical care measures, and I should say where possible. So we also have 7 guiding principles that build on existing humanitarian principles, but these are sort of the cross-cutting principles for the 14 actions. The first one is on mobilizing locally appropriate joined-up community-led initiatives. And the second one is on supporting local actors to lead the response. And this is supporting them by engaging with them, but actually giving them the material and other resources that they need to actually lead the response. We're advocating for working in politically and socially sensitive ways, and recognizing that duty of care for response workers at all levels is critical. I don't know if anyone joined. There was a fantastic webinar last week with MSF talking about case management and ethics of it. And I have that in mind also when I look at, establishing and sharing ethical guidelines for the response, not just for case management, of course, but across all aspects of the response. We also need to anticipate and work collectively to offset adverse secondary impacts. So again, this goes into our action on prioritizing other essential services. As well as to make sure that we're socially and economically supporting affected populations. And finally, this is building on a bit what John was saying at the start, which is investing in operational learning, research, and innovation efforts. I would like to leave you with sort of 3 key considerations. So we know that given the unprecedented nature of this pandemic, border closures, people working remotely, we know that operational responses for humanitarians will rely on national and local actors at the heart of it. We're also talking a lot about evidence-based learning, but we know that there's a lot we actually don't know. There's a lot of uncertainty and knowledge gaps about how the virus behaves, but also about the best interventions as well as the intervention modalities for the response. So this report we wrote is actually, it's based on the best available current knowledge as of about, I think it was a week and a half ago when it was published. But given the rapidly evolving evidence base on COVID, we will be updating the report, as Alice mentioned. So I'll just stop there. Thank you very much.
Great, thanks so much, Neha. And if you want more details, you can download the paper from our website. I'm going to jump straight to the panel and go to Linda. So you peer-reviewed the paper, you've read it, you're very familiar with the actions that are listed there. What actions are at the top of the agenda for the global health cluster in terms of preparedness and prevention of COVID-19 epidemics in humanitarian settings?
Thanks, Alice. Well, anything the Global Health Cluster does is frankly is only relevant if it's implemented at country level. So just to give a scope of what we're doing, we have around 900 partners across 29 countries who were already in humanitarian crisis before COVID hit, and the majority of those partners, over 600 of them, are national and local partners. So really they work with colleagues at partners at global level, but particularly with a focus to the coordination teams and partners at country level. 3 kind of areas to look at. 1, duty of care, to ensure that anybody in the field, whether that was through partners themselves, the coordination teams employed by WHO or others, were going to be safe and able to stay in post. So that whole kind of stay and deliver dialogue took place. That included the ability to maintain essential health services. So currently the cluster across the 28 countries is already supporting 65 million people. So how do we sustain those services? That has been quite challenging because of movement restrictions. So one of the first things that many of our partners started doing was surging locally. So hiring where they would normally surge in international staff was very much recruiting local surge capacity, and some quite interesting adaptive and creative approaches to that. Clearly the issue around supplies, around PPE, but also regular drugs and others took precedence very quickly. We, as everybody knows, there's been a huge, well, frankly, market collapse of many of the key items that we have. So at global level here, working across with the UN crisis management team and the supply coordination cell to try and get supplies to the people who need it. So at country level, this is very much working, deriving or estimating PPE requirements, having to make decisions about who gets PPE first, ensuring rational use of that. So for example, focusing very much on the rapid response teams that are going out for testing and surveillance, and then the frontline health workers, of course, who are actually providing services themselves. That remains extremely challenging for multiple reasons. In terms of key sort of COVID response activities, the first thing was really to assess the capacity of what was already, what services existed, and really looking at what COVID specific activities could be further integrated into existing services or existing outbreaks response modalities, and much of the COVID response is being done through that. However, that did require us to scale up some of those activities, particularly around risk communication, community engagement, IPC activities, around hand washing campaigns, very much in collaboration with the WASH cluster. Very early on in the conversation, our colleagues at country level were engaging with the shelter and camp coordination and management cluster around basically decongestion of high density areas. There was quite an early concern around the issues around camp or camp-like settings, how to both isolate and quarantine within those examples. That remains a fairly controversial discussion in some settings, because physically it is difficult to do just geographically in terms of the landscape available to people. But there are some quite nice examples where decongestion strategies have been put in place. That includes both creating isolation facilities to shield people, to protect vulnerable people, because even talking to people in the camps, they themselves, and even in family units, were not happy about having to potentially shield with individuals who may or may not be infected. So again, what we put in theory doesn't necessarily, is not necessarily acceptable in practice. Identifying COVID facilities where we could refer suspected COVID cases for treatment. Clearly, we wanted to separate that from existing health facilities. What we tried to do is at least adjoin as much as possible, not set up too many parallel centres, but certainly to make facilities available. Community mobilising, not only community health workers, but also community workers across other sectors to be used for both risk communication and surveillance activities in camps, and basic case management or case identification and case management. That requires a substantial amount of training and repurposing, task shifting of staff. Quite a lot of work with some of our cluster partners on the screening at points of entry. We're working in areas that have very fluid borders, and we have countries that perhaps had few COVID or no COVID cases, but adjoining countries with increasing COVID cases. So trying to put in points of entry screening, again, extremely difficult in highly insecure and difficult to access areas. We have areas now, at least 3 local government areas in northeast Nigeria with about 200,000 people, where there's absolutely no access to that population, yet we know there is movement, and we're hearing anecdote of cases. So again, constantly trying to adapt the outreach strategy to be able to negotiate access and undertake surveillance. And then on the coordination side, of course, that conversation, we already engaged in coordination mechanisms. Many of the clusters already well established outbreak coordination platforms with government-led emergency operations centres, but really then revisiting that whole engagement and how COVID is brought into that context. There's much more, but I only have 3 minutes, and I think I've probably taken that up. So over to you.
Great, thanks so much, Linda, and quite a lot to pack in 3 minutes. So that's really, really helpful. There's a question that's come in about one of the pieces that you mentioned there about shielding, and if there's a global health cluster position on shielding. I won't ask you to answer that right now. I'll let you think about that for a minute, because we'd like to hear from the other panelists first, but then we'll circle back around to those more specific questions. So I'm going to turn now to Iman, because we were talking about Linda's great point about how this is going to be playing out differently across different contexts. We see a difference between theory and what's happening in practice in different countries. So that's what makes the country level perspective so important. And Iman, you are working in the particular country context of Lebanon. So what are some of the key actions that you're seeing the humanitarian community in Lebanon take to prepare for COVID-19 in camps and with host communities? And also, there's been a lot of talk about this being a community-led response, and that's been very strong in Lebanon already in particular. So what is the role that community health workers are playing in Lebanon in this response from your perspective?
Thank you, Alice. Thank you so much. Actually, in Lebanon, soon after the first case reported in February 21st, the IMC International Medical Corps became part of the national cluster group. The humanitarian community in Lebanon coordinated together to respond to the national 8 identified pillars. Together, we adopted a unified guidelines for IPAC and PPE usage in the health facilities, camps, and also in the workplace. Together also we trained frontliners on IPAC and PPE usage, and also we trained health staff on triage screening process, on referral process, and on isolation for suspected cases, and also as well training them on IPAC and PPE usage. Also, we procured and we coordinated together as a humanitarian actors in Lebanon to procure PPE supplies to the primary healthcare centers. And we did this as it is mentioned in the ALNAP research paper as per the action 2, 4, and 6, exactly the same. Actually, there was like a fear in the community about what is coming on because of the cases. The fear was among the community and among the community health workers as well. So the country was locked down directly after a week of the first suspected cases. Although the PCR test was done for all suspected cases for free at governmental hospital and for free for a private hospital, but the level of fearness among the community was high. And for that, we invested on community health workers. We trained them, we equipped them with PPE supplies in order to provide or disseminate key messages on health awareness and COVID related topics to the communities. They did it through virtual phone calls with the beneficiaries, and they identified influencers in the community and they trained them as well. In addition, the community health workers, they collected information and things related to stigma to COVID-19, and as well clarity on the messages, because you know, for the social media, a lot of the messages, and it was very active in Lebanon. So there was a need to send a clear messages to the community, and it was done through the community health workers. As well, I can say that the community health workers played a very important role to maintain the access to primary healthcare centers, because of the cases were not referred to the essential services like vaccination, the children may be at risk. So in general, I can say that the empowerment that we gave to the community health workers by providing the correct messages to them, it was reflected in the community as a good feedback through the training, if we can say, to the beneficiaries and providing the correct messages. Thank you.
Great, thanks so much, Iman. So there was a question that came in about examples of community-led initiatives involving or regarding COVID-19 responses. I think you've given us a couple of really good concrete examples for that, so people can continue to look to the Lebanon case for more on that. Great, so over to Barbara to give us kind of the donor DFID perspective. How has DFID been pivoting to support preparedness and response to COVID-19? And what are the key actions that you think your partners should be focused on?
Hi, Alice. So I'll be speaking slightly outside of the scope of what Linda and Iman have covered, because of course DFID has had to take a multi-sectorial approach to COVID-19 in line with our remit. So there's been four pillars to our strategy so far. One has been to support the international coordination of the health approach. Second one has been to support the procurement of vaccines and potential treatments for COVID-19. The third has been to support the global economy and country-level economies, but also the most vulnerable, obviously. And finally, the fourth is about protecting trade and supplies, including humanitarian supply chains and obviously humanitarian access. And of course, the priority for us has been to identify what activities we could shift or reprioritize to help address the impact of COVID-19 and what we needed to maybe pose globally to enable that. But we've also been looking at how to channel funding to a lot of urgent interventions, so we can actually scale up or health interventions or humanitarian interventions or social protection programs in country, etc. And so examples of where we have been shifting involve, for instance, our health program in South Sudan, where we've been channeling funding to scale up preparedness in country and to scale up water and sanitation intervention as part of preparedness interventions. But beyond that health aspect, we've also been working with a range of other stakeholders, particularly through the G20 group, to identify other measures that could help low-income countries' governments release essential resources to support their health system and to support their population. So one of the initiatives we've been engaging with through the G20 has been about finding ways to support debt relief for a range of countries to enable them to use the money they would have normally spent on debt on the COVID response instead. And so far, that initiative has helped create up to $12 billion of additional fiscal space, so that this work across the G20. And as part of this initiative, we've also provided £150 million to the International Monetary Fund to also support debt relief. And so far, we've provided, broadly speaking, £744 million to support the COVID response, so both the primary and the secondary impact of the crisis, and we're channeling this, so not just to the IMF, but also to a range of UN partners, the Red Cross, NGO partners, to support both health and socioeconomic interventions. And one of the areas of work where we've been really looking to scale up has been particularly around the protection of the most vulnerable through social protection-based interventions and through cash transfers. So there's, roughly speaking, about 35 countries where we are engaging either through social protection or humanitarian cash interventions to try and support the poorest, the most vulnerable, the food insecure, refugees, IDPs, etc. And to enable this in those contexts, we've been scaling up not just our funding, but also our technical assistance offer to our own country offices, but also to a range of governments and stakeholders who are delivering these cash responses or these social protection interventions. And we're doing this together with Germany. And alongside this, we've been mobilizing our partners through the Grand Bargain Cash Working Group to try and learn from each other and identify how we can bolster this approach, understanding that we need to very rapidly be able to scale up our cash interventions on the ground. I'm just giving you a very brief snapshot, but I'll be very happy to go into more details as to what the UK has been doing. And so separately, what have we been asking our partners to do and prioritize? Well, there's a range of things. I think the first one has been to work together collectively around joint needs analysis and around scenario planning wherever possible. We're conscious that a range of stakeholders like us will be doing those exercises, but the potential impact of doing them collectively, and particularly of bringing together humanitarian development, international financial institutions, and other stakeholders, for instance, peace stakeholders, is really key to make sure we break down the usual silos. The second thing we've been pushing for is that partners really consider both the primary and the secondary impacts of COVID-19 and both the health and socioeconomic impact. So we're trying to look at that very holistically. The third thing is we are really pushing to maintain routine activities. And I think that speaks to a point that Linda was making across our health, humanitarian, social protection, and other interventions. We're conscious that protecting the services that exist, life-saving activities, essential preparedness activities is absolutely critical. And now more than ever, protecting, for instance, health systems from the impact of COVID-19, as well as enabling them to respond is key. So just maintaining these absolutely essential life-saving activities for us is one of the priorities. In addition, of course, we do need to flex our programs to adapt to new caseloads. So we are trying to work with partners to do that and to adapt to new geographies, etc., etc. In the health sector, I think in a snapshot, maybe one of the key messages for us at the moment is really focusing on prevention. Prevention in the health system, prevention at the community level, prevention in camp, understanding the challenges of what we can do to treat cases, and the fact that we have to work upstream where maybe we can reach the majority of people. So prevention for us is absolutely key. And finally, the last 2 points would be localization. I think we would all agree that local partners, the civil society, community level organizations are going to be absolutely key to deliver, but they're going to be key to help us communicate with the populations, to help us refine our public health messages, to help us understand the overall impact of the crisis. So I would say supporting local partners, not just channeling funding through them, but actually looking at supporting their capacity and engaging with them around program and response design for us is increasingly a priority. And finally, we have to be aware of the very large volumes of development financing that are being mobilized, particularly through the World Bank, but also through other international banks, bilateral donors, etc. So being aware of that and looking to integrate humanitarian caseloads, refugees, IDPs in national action plans and in the plans of development partners, and particularly the World Bank, is possibly, I think, our last big ask, because we have to be conscious that particularly around the socioeconomic impact of the response, there's only so much we can achieve through humanitarian financing, and we really need to leverage all those other actors that are out there. So that's really a quick snapshot, but I'll be very happy to develop. And back to you, Alice.
Great, thank you very much, Barbara. And really interesting to hear how much DFID has already done to move such a big ship in a way, and see all of the cogs and pieces that are changing around that. So not a very easy task, I'm sure. We're getting quite a few questions online, so I'm going to jump to a set of questions around case management, because there's a number of pieces that are coming up around case management and strategies for case management. So I think I'll put a more specific question that came in prior to the webinar to Iman first, which is around the strategy of home care isolation. So when dealing with people in a refugee camp setting who might have mild symptoms of COVID-19, is home care isolation recommended to deal with those cases of mild symptoms? What's been your experience of that, Iman?
So yes, actually, the humanitarian community under the umbrella of UNHCR did like an extensive exercise to study the specific case in Lebanon, because we don't have formal camps in Lebanon. We have collective shelters for refugees and informal settlements. So it was like a very specific case, and we worked together in order to put guidance on home isolation for cases at the overcrowded setting. So for that, we put this together a strategy, and we identified the cases into different levels according to the capacity of the camp. So at level 1, we said if the camp capacity as household level can have the suspected cases and the confirmed with mild condition cases, they can stay at household level. However, if the number of the cases increase, we will go to the level 2, while we will talk about community level. So in this case, when the capacity of the collective shelter or informal settlements was above the household level in terms of the capacity of the tent by itself. So we talked about having a specific place inside the camp to have the confirmed cases and the mild cases with mild symptoms. Of course, this like a coordination happened will be happening together in coordination with the health sector, WASH and protection sectors all together as one unified team. So, but in case the number of cases become larger in a certain camp and the capacity of the camp will not be enough for having all the cases, in this case we will go to higher level of intervention outside the camp at municipal level. And we identified it like specific locations in the like we can say the catchment area of the where the camps are available, and we coordinated together, as I said, all the sectors in order to respond, and we prepared a response emergency response team to respond in case we have cases. Till this moment, we don't have any case among the refugees, but it is a well-developed strategy available online for anyone who want to have more information at UNHCR website Lebanon, and this is what I can say. So it was recommended for mild cases to stay at the camp if the capacity of the camp can be enough. Thank you.
Great, thank you, Iman. And as you're aware, the isolation is one strategy among others. Shielding of vulnerable households is a different strategy that can be used. There's been a question from Bruno Abarca to Linda. What is the position of the Global Health Cluster regarding shielding? It seems that some actors are accepting interventions that focus on shielding and others are not because of different perceptions on the evidence around shielding. So I'll put that to you, Linda, and then go to Neha to talk about what are the trade-offs that decision makers are facing in selecting different case management strategies, and what resources could help them navigate those trade-offs. So first to you, Linda, on anything that the Global Health Cluster has put out in terms of a position on shielding.
So in terms of protecting at-risk individuals, I think quite early on we put a position out, a sort of interim position, which now over discussion, if people can refer to the Interagency Standing Committee guidance on implementing the public health interventions in low resource and humanitarian settings, that came out the 7th of May. So you'll see the section there on page 13 around strengthening prevention measures for individuals at risk of complications and poor outcomes. So as Iman kind of indicated, that should be done really at household level within a household of individuals that they're already cohabiting with. But clearly, even within that household, there needs to be some sort of physical distancing put in place. I think any recommendation to start creating collective centres in which you start putting older people or groups of other high-risk people to be avoided at all costs at the minute. I think there's pretty lousy evidence from well-established systems, i.e. the UK and others, where that just hasn't worked. I think what we're telling our colleagues is the level of risk of introduction of COVID is substantially high, and unless you can be absolutely sure that that risk is as low as possible, you should not be cohorting, creating collective centres of high-risk individuals. Now, we don't know how it's going to work at the minute at household level. The few cases that there are in the settings that we're in are being managed at household level. But as case numbers rise, and I think we all appreciate that, particularly in the African situation, where it's a very slow burn of the outbreak, and we anticipate seeing higher case numbers over the weeks and months, we have to manage that process. So it will require creative management of household settings, and this is why we're having lots of discussions with particularly our shelter colleagues and camp coordination colleagues. I think in Gaziantep, there's cross-border, there's been a nice example where they've been working with sheltering units, UNHCR coming up with sort of the refugee assistance units, which are essentially just very small prefab huts where you can literally isolate an individual, but not collective groups of people. So the evidence is very thin, and this is something we're going to have to closely manage, but it has to be about managing the risk of introduction of that virus. And we know in many of the settings we're working, the population movement within the communities, just as part of community movement and between communities, is higher than we would like it to be, and it's very difficult to stop that even when lockdown measures are imposed on certain areas. Thanks.
It sounds very complex. Neha, any thoughts on how to be navigating this complexity?
Thank you. Yeah, just to build on what Iman and Linda have said, I would like to start by saying that sadly there is no magic bullet we can use here. As Linda said, the evidence is very thin, if at all available. But we do know that in a very recent study conducted by Kevin Zandvoort and Francesco Cecchi and colleagues at London School, results show that in African countries, strategies combining self-isolation, moderate physical distancing, and shielding will likely achieve substantial reductions in mortality. And they also found that shielding of high-risk individuals, so these vulnerable groups, can reduce health service demand, which is something I think we really need to keep in mind when working in these extremely resource-constrained settings. And even more so, shielding can reduce mortality if it features high uptake and low contact, as Linda was just saying, between the shielded and unshielded people, with no increase in contact amongst the shielded people. But we do know that there's a difficult balance to strike here, especially taking into account the social, economic, and other impacts of these containment strategies. When it comes to shielding, it makes sense, I think, to introduce the strategy very early in the epidemic, or before cases occur locally, though communities may not have enough information or perception of the threat to engage positively with the approach. On the other hand, if shielding is rolled out only when transmission is intense, its impact will be limited, insofar as the high-risk individuals will be infected before they even have an opportunity to be physically isolated. Another disadvantage of introducing shielding midway through an epidemic is that it will be harder to prevent pre-symptomatic but already infectious people from mixing with the other shielded people that they may be housed with. So a reasonable timeline for rolling out the shielding approach would be, before transmission really picks up locally, conduct risk communication and community engagement with people, and work with them closely to help them co-design a shielding solution that works for them. And then, as soon as clusters of cases with local transmission occur, roll out shielding or advise communities to start adopting the strategy. I also want to stress that if prioritization of vulnerable people or shielding capacity are brought up as concerns, this suggests that the approach has been designed with insufficient community involvement, because the issue of space should not really come up if people are empowered and supported to design a solution that actually works for them. It's about swapping houses and accepting more overcrowding amongst low-risk people, not creating more housing or worse, tented isolation camps. Basically, there should be no competition for space between shielding and other interventions. And I would just like to end by saying that this is, I think the shielding and also other sort of containment approaches should not be turned into highly regulated top-down or even coercive operations that beneficiaries are unable to support themselves and their neighbors. To go back to, I think, what a lot of us are saying on this panel, the response really has to be what we're saying, locally led, done very closely in respectful consultation with communities on what works for them.
Great, that's a perfect segue to the next set of questions, which are around this point of community engagement, because it's so important, but at the same time, limitations to face-to-face interactions are making kind of preferred or traditional channels for getting feedback and consulting with communities more difficult. So Barbara, a question to you, because DFID has done a lot of work supporting the humanitarian system's approach to accountability to affected populations. How can we adjust feedback, complaints, and accountability mechanisms when our preferred channels of communication are blocked or not possible?
So a big question. I would say that the first thing is we're strong proponents that communication with communities and accountability is not just something that needs to exist at program level, but we believe in the value of collective independent platforms that engage with communities. And this is something we've supported in a range of contexts, including in Cox's Bazar, with quite tangible results in terms of improvements in the sense of the communities that they were able to engage with the decisions that concern them. So I think now more than ever, we think that these are the sort of solutions that we really need to collectively invest in. Practically, obviously, there are a range of access issues that are coming on the line. So looking at how to leverage mobile technology, but also where possible, having again, inter-agency mobile platforms to promote accountability is an option to explore. If needed, looking to leverage crowdsourcing and working not at all in a humanitarian niche, but actually working with public health actors and other actors to try and look at how crowdsourcing can support strategic work could be an approach. But we also think that technology is not the silver bullet, and we are going to continue engaging with communities. There's a range of contexts, there's a range of locations where direct face-to-face engagement is really what's going to be critical. And oftentimes people may want to channel their views through leaders that they trust. So we also need to look at leverage those community platforms that already exist, or piggyback on community-based interventions, including public health based interventions, to try and gather the views of the population, but also to give them an opportunity to engage with the more strategic planning process. So yeah, these are some initial considerations, but again, this is a fairly unprecedented type of crisis in its scale, in the number of people it will affect. So I think we're going to be also looking to see how we can encourage innovation in the way we work, including innovation at the level of humanitarian country team, to try and again engage with populations, engage with the civil society. So I think for us, it's also very much work in progress.
Great, an area for us to see innovation and learning come out. I want to move then to Aman and ask this question, similar sort of question, but around support for local partners in COVID-19. Given that many international NGOs aren't able to send field teams and do face-to-face trainings, there's also been a follow-up question online from Ashley at World Vision around how do we, picking up on your comments about training community-based health workers, are there approaches that you can recommend for training community-based health workers in a low-tech sort of way that still works with the restrictions around COVID-19? And then also thinking about avoiding top-down approaches to prepare local partners for COVID-19 preparedness. What are you seeing that's working well in terms of that?
Okay, thank you. So to respond to the first question, actually in Lebanon, IMC strategy from the beginning, even before the COVID-19, to build the capacity of the local NGO. So it is our main focus in Lebanon to strengthen the capacity of local NGO. So we work together for a long time to enable them to respond to outbreaks, and they responded to outbreaks with minimal intervention from us international NGO. But however, for COVID-19, because it is very specific, it needed additional support from us in terms of resources or more information. But with also this support, they were able to manage and cope with the situation with minimal guidelines or physical presentation of IMC team at the field level. And I want to strengthen about this important point, because as everyone knows that COVID-19 is a global now problem, and we don't know till when it will continue. For that, a humanitarian community should think about strengthening the capacity of local NGO, as we are doing here in Lebanon. I believe for normal situations, the local actors, health actors in Lebanon, they can manage now, they can manage their work with, as I said, with minimal support of international NGO. To go to the second question, which is related to the community and the training, actually, because we have built also the capacity of the local community has community health workers from the refugees community or from the local community since long time. There was a platform of we can say virtual training that we did for them, and it was successful through here in Lebanon. Mainly they use the WhatsApp platform, so it was a video calls. It was really a good method to train the workers, and in the same way they train the beneficiaries through this WhatsApp video calls, basically to train, let's say, the children had proper hand washing and things like this. So training it was not an obstacle, because we were able to do it through the virtual calls or videos or any social media platform.
Great.
I don't know if I missed anything from your questions.
No, that's perfect, and really good concrete examples. I'm just going to flag the time. We're coming up to the hour. We did ask the panel beforehand, and they can stay on for an extra 10 minutes to help continue answering people's questions. So you're welcome to stay on 10 minutes past the hour with us. And I'll go straight back to Linda to ask about this piece on coordination. So we had a few questions before the webinar about how humanitarians should be working with each other and how they should be working with development actors most effectively for COVID prevention. Coordination is obviously so essential to COVID-19 response. What lessons can we learn from previous epidemic responses where maybe this didn't work as well as we would have liked to? And on the other hand, what are some of the issues that are going to make coordination for COVID-19 unique and different from those previous epidemic responses?
Thanks, Alice. That's a fairly multiple question. On the humanitarian development bit, actors, I think we're inclined to, certainly colleagues in the field, look at it in a slightly different way, that in many of the places where we're already working and where we now have to deal with COVID, this is a health sector requirement. The health sector needs response, and if there are health actors, regardless of whether they define themselves as humanitarian or development, if they have a presence, they have a role to participate. The issue there is obviously to ensure that we're mutually reaching out to each other, understanding that what our existing activities and everything are. But in many of the places we already work, there are local actors there who don't necessarily define themselves as humanitarian per se, but are the ones who are providing support. I think what's important then is with the actors that you work with, that there's a mutual understanding of that principled health action that's required to deal with the particular protection and vulnerability issues that disaster-affected populations require. I think where we have some examples as well in some of the more protracted crises where, again, pre-COVID, there are increasing moves to where the humanitarian coordination platform, which may be the cluster or sector, more regularly meets with the development actor platform. I would say certainly Northeast Nigeria is a good example of that. So again, where these mechanisms are already in place, it's about ensuring that conversation is refocusing its efforts on the specificities of COVID. In terms of what did we learn from before? Well, I think we, as is very clear in the Global Humanitarian Response Plan and reiterated in most messages that come out about the risk response, is work within the existing systems. Let's not start developing additional entities or parallel processes because people feel that's a fun thing to do. No coordination mechanism is perfect, and they never will be, but you can build and strengthen on the existing entities that are there, and obviously help, whether it's at a health sector level, but also more importantly, because this is a whole of a multi-sectoral response at the inter-sectoral level as well, to bring those actors together. And that requires obviously reinforcement of coordination capacity, preferably as decentralized as possible, to reach the populations in need, but also to help localize that response. And I think we're seeing that support to local coordination capacity happening, but that support needs to be consistent, and again, not just funding. Again, as I said earlier, many countries already have their emergency operations centres, whether those are health specific or through a wider national disaster management entity. So it's important that humanitarian actors understand, whether that's through the cluster or other humanitarian platforms, how that platform interfaces with the emergency operations centre and the incident management system that is therefore running the response and the different pillars of the response. And again, people have something to offer. We see already, we're already established programming. We have cluster partners co-leading some of the EOC pillars or providing technical advice to these EOC pillars, but more importantly, implementing the actions that are coming out or being determined by that incident management system. But it is about a willingness to engage and also understanding what you as an actor, whether you classify yourself as humanitarian development or whatever, what is it, your particular skill and capacity, complementary capacity you bring to that setting. And it's through that engagement, somebody mentioned, I think it was Barbara and others, emphasizing the issue on community engagement. If you don't have that interface, we will repeat what we've seen in previous, whether it was Ebola in 2014 or the recent review that was done of DRC and other mechanisms. If you don't have that effective interface, you lose essential entry points in the response preparedness and response mechanism. So the lessons are there, but there has to be a willingness on all sides to engage on that. Thanks.
Great, thanks so much, Linda. Equally as important as coordination is also having adequate data to inform decisions and data that's shared across different partners and agencies. So Barbara, what are you seeing as being some of the emerging data gaps that you wish you could fill or want to see filled over the next few months? And what role is COVID-19 data playing in DFID's approach to the emergency response?
So I would say there's, particularly in humanitarian emergencies and in fragile and conflict states, there's data gaps across the board, of course, as we know. On the health front, I would say strengthening surveillance mechanism is quite central to all our health programs, and this is something we're really focusing on with local health systems and working obviously with WHO. The biggest challenge may be around data concerning this bigger social picture, because we know that situations are changing incredibly fast, that there's a range of countries where levels of food insecurity and extreme poverty and needs may already have changed drastically because of a range of factors, including potentially containment policies. And we're not necessarily able to measure this in real time. So that's a challenge. So obviously, agencies like WFP, like FAO are already playing an absolutely critical role on this. As a development donor, DFID also engages with others, and the World Bank, for instance, is one critical partner in this area, as is, for instance, UNICEF. So I think our focus is really going to be on what the key multilateral partners are doing to try and help address access issues, the fact that a range of country-wide surveys will not be feasible in the traditional manner, and to try and find alternative methods, including through a different approach to sampling or surveillance sites, etc. So we're really going to be keen to see multilateral partners particularly show their leadership there. And then finally, we come back to the issue of engaging with communities. So beyond the big data on what is happening at country level in specific region, at a community level, having that qualitative engagement with communities is not going to provide quite the statistics we may be after to know whether we're moving to IPC4 or IPC5. But as Linda was pointing out, it's very much going to tell us whether we're on the right tracks or on the wrong tracks in our public health response, for instance. So yeah, but again, this is also an area where we're learning as we go, and I think we're going to be really open to learning more about what needs to be done and also what catalytic role we can play as a donor.
Great, thanks, Barbara. A couple of people are asking about stigma in the communities, particularly locally based actors in Northeast Nigeria and I think also Somalia. So it'd be good to ask you, Neha, if anything came up in your research, and then Iman, if there's anything from your practice that you could use to speak to this issue. So the question is around what can humanitarians do to prevent and address stigmatization experienced by COVID-19 survivors when they return to their homes and communities? What would you advise humanitarian actors to look at there?
I think I'll be very brief because I think it'd be nice to hear from Iman on actually what's happening right now. But I can talk about evidence. Well, there's a lot of evidence from the Ebola response on both things that went well for this and things that didn't go so well for this. And I think when it comes to stigma, I think destigmatizing, the experience of actually having COVID-19. So actually using, working with, if we want to call them survivors or whatever we want to call them, of people who've recovered from COVID-19 to share their stories, to talk about, their experience from whatever their experience was. And that, I think whether they're being tested or treated is going to look very different depending on the type of setting it is. So I think I keep coming back to this bottom up, working with communities, but actually empowering community members, including those who have had COVID or those who have looked after people with COVID, to talk about it and to sort of demystify it a bit. And I think there's also a lot being done. Well, there was a lot being done for Ebola, but also for COVID on rumor tracking. And that also helps to address some of the rumors and the stigmas around COVID-19. So again, just working hand in hand with communities to work out, what is the stigma, first of all? How can you address it? How can you work with the relevant stakeholders to address it? What do they want to hear? In what language, in what form?
Great, thank you. Iman?
Yes, I can add only that Lebanon, as other countries, the stigma and the bullying was like at high level in Lebanon. And as I mentioned earlier, the community health workers, they fighted this through the providing the good messages to community. Also, we reached the cases increases to mental health. So the mental health case managers were available online, also using the hotlines to respond to any questions and to try with the community health workers to solve this problem. In general, in the community in general, like the celebrities in Lebanon, like they in the newspaper and in the news, they sent this message about fighting the stigma, and it is not shame. However, the problem, what Neha said, like between patient confidentiality and between telling the cases with COVID-19 to tell about their story, there was not a balance. So between having COVID patient confidentiality and between not to tell about the cases, there was a problem not to know what to choose as a community and what to say. But I can say in Lebanon, unfortunately, a lot of cases when it was unknown. So not only the family of the patient was under the pressure of stigma and bullying, but even the village or the city where this person lived. So it was a huge problem in the country, but they are trying to eliminate it through sending correct messages through the Ministry of Public Health, through the community workers, and also go to the levels, if I can say, as I said before, for celebrities to inform the community. It is not a shame to have a COVID-19.
Great, thanks very much, Iman. So just to get some celebrities involved, that always helps. So that's a good point for people to follow up on, but also being aware of the balance that needs to be put into place there with confidentiality for individuals who have recovered from those cases. Good. So we're just nearing time. Before we go to the last round of questions for our panelists, I want to highlight two opportunities for everyone listening to this webinar and who's been involved in sending questions beforehand. Two opportunities for you to engage. We've been talking talking a lot about the importance of engagement and collective learning. So putting that into practice, as we've mentioned a couple of times here, ALNAP will be updating this rapid learning review later in the year based on emerging evidence and practice. And we'll have the opportunity for you to feed into those revisions based on your own learning and experience. So if you'd like to participate, please go to our website at alnap.org and go to the bottom of the page where you can subscribe to our newsletter, and that's where we'll be sharing information on how to join the revision process for the paper. Also, the London School of Hygiene and Tropical Medicine and CERAH are hosting a collective platform to collect field experiences from practitioners on how they're operationalizing guidance on health, education, protection, and other areas. So you can contribute your field experiences at that website, which I think will be put up also in the chat box, but it's www.covid19humanitarian.com. So go there to contribute your field experiences, and that will help generate a better body of knowledge for all of us on effective approaches to COVID response. So we've all been saying how much we don't know about COVID-19 in humanitarian settings. I want to conclude by going around the panel and saying thank you very much for contributing all that you do know at this point in time with us today. And also a question to you on what is the #1 issue or question that you have in your mind that you would like to be seeing better evidence for in the next few months? So what kind of question or issue do you hope will have better answers to, or what you would like to see better answers to about 6 months from now? So I'll start with Barbara.
I would say Alice would want to see the real-time socioeconomic impacts of this crisis evidenced, because we know that the overlapping effects of COVID-19, so the impact on macroeconomic dimensions, trades, but also containment measures, etc., altogether will be different from country to country. We know that we might see new pockets of extreme poverty and of need in urban areas where humanitarian actors were not present before, that certain rural areas might actually not be proportionally quite as heavily affected. So really understanding that impact, particularly on the most vulnerable, on people already suffering of food insecurity and already in extreme poverty and in need, is for us possibly the most critical aspect. So, so we know where to intervene, and particularly where to anticipate tipping points where people might be moving, for instance, into IPC4 or even IPC5.
Great, thank you. Thank you, Barbara. Neha?
Thank you. So I think I have many burning questions, but one I've been thinking about a lot is I would love to know what is the best way to prioritize and maintain, as well as to deliver, essential routine health services. Again, thinking about mitigating the adverse effects, the secondary impacts.
Great, very important question. Linda?
Well, I'll second what Barbara and Neha have said, of course. Of course, there are multiple questions around what we've just talked about: case management, community case management, isolation, etc. So clearly we want to capture some of the real-time experience that our colleagues are dealing with now. I think there's quite a lot of questions around issues around comorbidities, particularly issues around interface with TB, HIV, under malnutrition. We're getting these and you know, there's not much out there, there's nothing out there, so I think we'd be interested to hear more about that. And then frankly, on the localization word, I mean, it's used a lot, it's bandied around, we all know what we're supposed to be doing around that in the grand bargain, but really, is this another opportunity that we're actually going to capture and strengthen and really be overt around localization, or is this just rhetoric again?
Great, thank you. And Iman, finally, what are you hoping to know more about a few months from now?
Yes, I think from my side, I think we should know more about how to ensure or maintain the access to the essential services, health services, by using new technology, as Barbara said, telemedicine or other methods, and how we can gradually return to the full capacity at the health services, especially at the level of a primary healthcare system.
Great, all important questions, and hopefully when we come to revise the paper with Neha a few months from now, we'll have at least partial answers or on the road to answers. So in the meantime, I want to thank our panelists again for sharing the wealth of knowledge that they have at the moment on COVID-19 and their experiences. Thank you to everyone who's been participating and sending in questions. And again, the webinar, this webinar will be available online. A video of it will be available online. And please feel free to follow up with the LNAP Secretariat on our website if you have questions or suggestions for new additions to our portal. Thank you very much and have a lovely rest of your afternoon.